Welcome back to AudioBoards. Today we're covering hyperosmolar hyperglycemic state, or HHS. This is one of the most dangerous endocrine emergencies you'll encounter in the hospital. Unlike DKA, where ketoacidosis drives much of the presentation, HHS is primarily a problem of profound dehydration and hyperosmolarity. Patients often present with glucose levels exceeding 600 milligrams per deciliter. Effective serum osmolality above 320 milliosmoles per kilogram, severe volume depletion, and significant neurologic dysfunction. Mortality remains substantially higher than DKA, largely because these patients are older, have more comorbidities, and frequently present later in the course of illnesses.
So the management priorities are a little different than DKA.
Exactly. In DKA, insulin is often the star of the show. In HHS, fluids are the star. The major pathophysiologic problem is severe water depletion. Many patients have total body water deficits of 8 to 12 liters or even more. The hyperglycemia causes osmotic diuresis, leading to progressive dehydration, rising serum osmolality, worsening hyperglycemia, and eventually altered mental status. The cornerstone of treatment is restoring intravascular volume and gradually correcting hyperosmolarity while avoiding overly rapid shifts that could precipitate cerebral edema.
Before discussing treatment, let's briefly review the diagnostic criteria.
Yes, HHS is diagnosed when all of the following are present: plasma glucose at least 600 milligrams per deciliter, effective serum osmolality greater than 300 milliosmoles per kilogram, or total serum osmolality greater than 320 milliosmoles per kilogram. Minimal ketosis defined as beta-hydroxybutyrate less than 3 millimoles per liter, or absent to mild ketonuria. No significant acidosis with pH at least 7.3 and bicarbonate at least 15 milliequivalents per liter. Many patients may have some ketones, but they do not meet criteria for DKA.
What's your first step when HHS arrives at the department?
Always start with the ABCs. Assess airway, breathing, circulation, mental status, and hemodynamic stability. Many patients present with severe dehydration, hypotension, tachycardia, acute kidney injury, or altered consciousness. Obtain a full metabolic panel, magnesium phosphate, serum osmolality, venous blood gas, beta-hydroxybutyrate, CBC, urinalysis, ECG, and evaluate for precipitating causes. Common triggers include infection, myocardial infarction, stroke, pancreatitis, glucocorticoids, atypical antipsychotics, diuretics, medication non-adherence, and previously undiagnosed diabetes. Treating the precipitating cause is just as important as correcting the glucose.
Now let's move to the management framework.
Yes, think. Fluids, potassium, insulin, monitoring, and transition.
That's the sequence.
Yes, let's start with fluids. The initial fluid of choice is isotonic crystalloid. Most protocols begin with 0.9% normal saline or another isotonic crystalloid. Give 1 to 1.5 liters during the first hour, which roughly corresponds to 15 to 20 milliliters per kilogram. If the patient is hypotensive or in shock, administer more aggressive resuscitation as needed. After the first liter or two, reassess hemodynamics, urine output, sodium concentration, and serum osmolality. Fluid replacement should continue over the next 24 to 48 hours because these patients often have enormous free water deficits. The key principle is gradual correction. The serum glucose and osmolality should not fall too quickly. The consensus report recommends avoiding a decline in serum osmolality greater than approximately 3 to 8 milliosmoles per kilogram per hour. Rapid correction increases the risk of cerebral edema, especially in younger patients and those with profound hyperosmolarity.
Can fluids alone significantly lower glucose?
Absolutely. That's one of the most important differences from DKA. Simply restoring intravascular volume improves renal perfusion and increases urinary glucose excretion. Glucose commonly falls by 50 to 70 milligrams per deciliter per hour with fluids alone, and sometimes even faster in HHS. That's why insulin is often delayed until initial fluid resuscitation has begun. Now let's talk potassium. Just like DKA, total body potassium stores are depleted even if the initial serum potassium appears normal or elevated. Osmotic diuresis causes large potassium losses. Before starting insulin, check the potassium. If potassium is less than 3.5 milliequivalents per liter, hold insulin and aggressively replace potassium first. If potassium is between 3.5 and 5.0 milliequivalents per liter, begin potassium replacement along with treatment. If potassium is greater than 5.0 milliequivalents per liter, do not initially replace potassium but monitor frequently because levels often fall rapidly once insulin therapy begins. Potassium should generally be maintained between 4 and 5 milliequivalents per liter during treatment. Electrolytes should be checked every 2 to 4 hours during the acute phase.
So fluids first, potassium assessment second, and only then insulin?
Exactly. One of the most common mistakes is starting insulin immediately before adequate volume resuscitation. In HHS, severe dehydration is the dominant problem. Insulin is important, but it is not the first intervention. After volume status begins improving and potassium is safe, start intravenous regular insulin. The guidelines recommend a lower insulin infusion rate for isolated HHS than for DKA. Start regular insulin at 0.05 units per kilogram per hour intravenously. Notice that's half the typical DKA infusion rate of 0.1 units per kilogram per hour. For a 100 kilogram patient, that would be 5 units per hour. The target glucose decline is approximately 50 to 75 milligrams per deciliter per hour. If glucose is not falling adequately, the infusion can be adjusted. Once glucose reaches approximately 250 to 300 milligrams per deciliter, add dextrose-containing fluids, usually D5W or D5 half normal saline depending on the patient's sodium and volume status. At this point, continue insulin while maintaining glucose around 200 to 300 milligrams per deciliter. The goal is no longer rapid glucose reduction. The goal is continued correction of hyperosmolarity and recovery of mental status.
Why not normalize the glucose immediately?
Because glucose isn't the only osmol. If glucose falls too rapidly, serum osmolality falls too rapidly. Water then shifts into cells, including brain cells, increasing the risk of cerebral edema. That's why HHS management is really the management of osmolality rather than simply the management of glucose.
Okay, let's discuss monitoring.
Yes, in the monitoring phase, glucose should be checked every hour while receiving IV insulin. Electrolytes, creatinine, and potassium should generally be checked every 2 to 4 hours. Monitor neurologic status closely. Monitor intake and output. Monitor vital signs and volume status. Calculate effective serum osmolality repeatedly. The effective serum osmolality formula is 2 times sodium plus glucose divided by 18. Remember that sodium must be corrected for hyperglycemia when interpreting laboratory values.
How do we know when HHS has resolved?
Resolution is not based solely on glucose. HHS is considered resolved when mental status has returned to baseline or substantially improved. Serum osmolality has normalized, typically below 300 milliosmoles per kilogram. The patient is adequately hydrated. Glucose is controlled and stable. The precipitating illness is improving. Unlike DKA, you're not waiting for an anion gap to close because ketoacidosis is not the defining abnormality. Now let's discuss special situations. Patients with heart failure, advanced kidney disease, or significant cardiac dysfunction may not tolerate aggressive fluid administration. In these patients, frequent reassessment of volume status is essential, and fluid rates should be individualized. Phosphate replacement is not routinely recommended. Consider it only for severe hypophosphatemia, respiratory failure, cardiac dysfunction, or profound muscle weakness. Bicarbonate therapy is generally not indicated in isolated HHS because significant acidosis is absent.
Finally, transition to subcutaneous insulin. When do we do that?
Once the patient is eating, clinically stable, and hyperosmolarity has resolved, transition to a subcutaneous insulin regimen. Administer long-acting basal insulin at least 1 to 2 hours before stopping the insulin infusion. That overlap is critical to prevent rebound hyperglycemia. If the patient was previously on insulin, resume an appropriate regimen. If newly diagnosed, calculate a basal bolus regimen based on body weight and inpatient insulin requirements.
Let's finish with a bedside framework.
When you see HHS, think. Confirm the diagnosis. Glucose at least 600 milligrams per deciliter. Effective osmolality above 300 milliosmoles per kilogram or total osmolality above 320 milliosmoles per kilogram. Minimal ketosis, no significant acidosis. Step 1. Aggressive isotonic fluid resuscitation, usually 1 to 1.5 liters in the first hour. Step 2. Check potassium. If potassium is below 3.5 milliequivalents per liter, replace potassium before insulin. Step 3. Start IV regular insulin at 0.05 units per kilogram per hour after initial fluid replacement. Step 4. Target glucose decline of 50 to 75 milligrams per deciliter per hour. Step 5. When glucose reaches approximately 250 to 300 milligrams per deciliter, add dextrose and continue insulin. Step 6. Monitor glucose hourly and electrolytes every 2 to 4 hours. Step 7. Avoid decreasing osmolality faster than roughly 3 to 8 milliosmoles per kilogram per hour. Step 8. Treat the underlying trigger. Step 9. Transition carefully to subcutaneous insulin with a 1 to 2 hour overlap. If you remember that HHS is fundamentally a disease of profound dehydration and hyperosmolarity, you'll consistently prioritize the right interventions. Thanks for listening to AudioBoards. Stay tuned for more educational content in our next episode. The views and opinions expressed on the AudioBoards podcast do not necessarily reflect those of our employers. This podcast is for educational purposes only and should not be used to diagnose or treat any medical conditions. It is not a substitute for professional medical advice. Always consult a qualified, board-certified healthcare provider for any medical concern.